So this lesson is going to be on issues in educational settings. So the next few chapters in this book divide issues up based on kind of where they're most likely to be seen based on a work setting. It's kind of a unique way to go about doing this, but that's okay. We'll roll with that. And in reality, these next few lessons are really going to test our model of kind of doing this high level overview because there's some real nitty gritty specifics that we'll need to get into. So I'm really hoping you'll spend some additional time in the textbook this week, as well as make sure you ask any questions that you have that might come up. And then in class, we will spend some time getting into some more of the specifics while we use some of this within our semester project. So when we start talking about the educational setting, this is really where athletic training traces a lot of its roots back to. And so sometimes these are referred to as like the traditional setting and everything else are the emerging settings. And in reality, that's probably the best way to describe it because it's quickly becoming that that's not the predominant area anymore. I think the emerging venues and areas are going to end up being more common than the traditional setting here in the future. So when we look at that, because of the birthplace of athletic training within the educational setting, there's been a large tie from the very beginning with athletics and with the athletics structure. And so in today's day and age, we have to ask the question, does that athletic structure continue to serve us well? And so this is the little joke that I kind of go with. If you remember from the movie Miracle, Herb Brooks asked, who do you play for? And asked that question over and over and over again until finally someone replies with, I play for the United States of America. And the importance with that is it signified a mental shift in their mental model of who they were as a team. And it's been proposed, and I believe that's probably time as well for athletic training to go through a mental model shift. And that only can occur in each individual's mind. So I want to take a little bit of extra time here and ask you the question, who do you work for? And so when you answer this question and you think about it, it's relatively simple to say that your highest priority is always the patient. But is that really where your mind is? Do you see yourself as a medical professional that works with athletes? Or do you see yourself as a member of the athletic staff that does medicine? And this is really important not only from a potential conflict of interest point of view, but also from a reporting structure and a pay structure. If you think about it, oftentimes there's this premise that people working with higher quality athletes by definition then are higher quality professionals. At the same note, for years and years, there's always been these $15,000 a year internships at large institutions where certified athletic trainers, usually right out of school, will go. They're not even GAs anymore. They're just getting paid very, very little in order to be the grunts of these big programs. And people always apply because there's a certain coolness to being part of these big programs. And I label this the whole like swag and the amount of clothes and stuff you get. At the same note, on your polo shirts and the stuff that you wear and how you identify yourself, do you see yourself as a member of the medical team or, closer to the coaching staff? Now, there's nothing inherently wrong with seeing yourself as part of a coaching staff, but there is the potential problem with conflict of interest where if you're supposed to be the medical professional providing the care for the student athlete, and you also are getting bonuses based off of postseason play, or you get too enamored by chasing a ring or whatever, that sort of aspect, that could become a conflict of interest. On a completely separate note, but probably more important and will ring home with more people, the term assistant athletic trainer comes from the coaching model, where you have a head coach and you have assistant coaches. And because of the fact that assistant coaches usually are relatively inexperienced and they don't hold ultimate responsibility for anything, they've traditionally and continue to get lower salaries. Well, there really is no such thing as an assistant athletic trainer. There are athletic trainers that provide care for different athlete groups, but each athletic trainer is going to work independently as an independent medical practitioner. So really, we can have like a director of sports medicine and then the head athletic trainer for name the sports, right? Because those people are in charge. And so you think about where the problem of being labeled and supervised within the athletics department comes into play, because you get paid based off of this assistant coach model. Whereas if in the more medical model, where athletic trainers leave the athletics department, they still obviously work with the athletics department, but they are part of student health or some other outside organization, they're now working directly in collaboration with nurses and physician assistants and doctors and whoever's providing the health care for the remainder of the thing. And in medicine, right, we don't have assistant doctors. We don't have assistant nurses. We have nurses that provide their own care. We have doctors that provide their own care, and they get paid accordingly. And so removing athletic trainers from this traditional educational setting linked with athletics will be a large portion to actually having athletic trainers get the pay and respect that they deserve. So again, I want you to spend a little bit of time just thinking about, when you're in the athletic training, when you're there, do you see yourself as part of the team, or do you see yourself as part of the medical team? So some of the other sorts of things, there's just a lot of different things in this chapter that we're going to hit, some a little bit bigger than others, but these are all going to require additional individual study, not so much in this class, but we will review some of these foundational documents over January term. So let's start with operations, and the biggest thing to understand in overall operations for all of these things is the difference between practices, plans, and then these policies and procedures. So when we think about the practices, this is the specific tasks, policies, and procedures, and then the plans are the higher level things. So policies and procedures provide this clearer understanding of function. So you will have a policy that will describe what we need to do or what the goals are, and then procedures on how to get that done. So you can have a policy of maintaining daily cleaning within the athletic training room, and the procedures are all of the different things. What sort of chemicals do we use, who cleans what, all those aspects. And so these provide a good uniform guide for this daily operation. And when we talked about risk management, we talked about policies and procedures a little bit, because this will standardize the care amongst different groups, and thereby making sure that we're always providing the standard of care. Another one that we talked briefly on, but is really important with that, is emergency planning. We will go through the specifics of the emergency planning components there. But when we think about that, right, remember it needs to be venue specific, right, and it has to have clear communication and role delineations. We talked about the pre-participation physical a little bit as well, so let's talk a little bit about how, or some specific issues with this. All right, the pre-participation physical exam is recommended by just about every supervising organization. The reasons to conduct the pre-participation physical exam, right, are listed there. Basically, you're looking for any disqualifications, but you can use the pre-participation exam also for baseline measurements for the purpose of improving health and performance as well. But the two big questions that often come into play, with the first one having two kind of answers, is who performs the pre-participation physical exam and when are they performed. We'll start with when, and when is ideally 6 weeks before the start of the season. This will allow for additional diagnostic testing. When you have pre-participation exams right before the start of practices, which is fairly common, the problem comes is if there are any red flags, now your athlete has to decide whether or not they're missing or not, or the healthcare professional decides whether or not that red flag is enough to disqualify them and actually have them miss time. It's a lot easier to do follow-up testing if you've done it ahead of time. But as far as who does the pre-participation physical exams, there's really two main types, right? Because the pre-participation physical exam needs to be done by a qualified healthcare provider, and really you're looking at doctors, maybe nurse practitioners. Other people have done those, but you need somebody that does these on a regular basis and has the experience needed to identify these potential life-threatening conditions. So then it really comes down to, well, what physician, what group, how do we go about doing that? And that is then the idea of office-based versus station-based. And so the best way to probably do that would be to have each individual see, or probably the best, if you could, would be a combination of all of this where you almost do both. But having the patient see their normal family physician, right, in their office will allow for the most thorough physical exam. Like there really shouldn't be a huge difference, but there obviously is between the sports physical and the annual physical, right? The sports physical should never replace the annual physical that is recommended for individuals to get, but often it does. So using the annual physical model is much more thorough. But in reality, the problem with that often comes is you have to get a lot of people through. Athletes aren't always good at scheduling their own thing, so you do some sort of station-based aspect where they work through and you have a sports physical night that gets a lot of people through, but like it can feel rushed and you may not have the highest quality person providing some of those aspects. But in some cases, you might have better qualified people, like if you have an athletic trainer doing the musculoskeletal assessment, right? That's probably better than your general medical doctor would be able to do. And so that's a positive there. But regardless, either way, the most important thing is that you put the first things first. And what that means is, regardless of how the physical is done, the history needs to be completed first, so that way it can be used as the basis for interpreting the physical findings that are found on the patient. Meaning, if somebody has the presence of sudden death in their family, right? We're going to be looking a lot harder for potential cardiac things than not. And so if we do the cardiac exam and then find out that they have a history of sudden death in the family, we would not have scrutinized them, or we would not have scrutinized them as much as we would have we already known that. So regardless of the structure, the history needs to be performed first so it can be reviewed within each of those stations. Some of the most cardiac issues, we'll go through specifically all of the different recommendations there, but you can see some of the cardiovascular issues and some of the history that are most important for those athletes to mention, so that way we can do their physical findings based off of a higher chance of cardiac conditions, as well as a lower threshold for follow-up exam. Next specific issue is drug testing, and drug testing is much more complicated than we're going to get into in this course at all. We mentioned in the risk management the potential problems with search and seizure rules with drug testing, because drug testing is considered a search. But drug testing is becoming much more widespread within that. And really, when we talk about drug testing, there's 4 really important things that need to be considered. There's more lists within there, but the 4 most important are: you need to have a list of what you are going to be testing for in the banned substances, and the NCAA does that, right? You need to have a committee with representatives to help make decisions, right? And then you need to have data on potential false positives and false negatives for the specific test you're going through, and then establishing a policy for confirming positive results. If you're going to remove somebody's eligibility, you need to be specifically you got to have a higher threshold. And so usually when you're doing drug testing, for the purpose of costs, they will run a cheaper preliminary test, and if that comes back positive, we'll run a more sophisticated test on the sample to confirm with that. And so that really all comes down to your entire process and thought. But again, if you're doing drug testing, it's utmost important that you put these 4 procedures in place, but all done within the idea that this should be considered an educational aspect to help people with potential problems, opposed to a punishment mechanism. Another area that becomes problematic specifically in the educational setting and the athletic setting has been the history of medications. And so at a lot of the bigger schools and universities, they have physicians that work with their sports team. So the use of prescription medication within the sports medicine team is a lot higher, and it goes through the sports medicine team opposed to local pharmacies and all that. So they have prescription medication on site. And so that potential problem or risk has really been problematic and has been abused in numerous situations. And so you have to think about medications from the standpoint and the rules that would be at a pharmacy. And if you do have prescription medications within your athletic training facility, there needs to be very strict protocols for handling those medications. So let's get with a couple of really important terms to understand. First is administration, and that's delivering a single dose of a drug. Anytime you're delivering multiple doses of a drug, right, as far as preparing, packaging, right, that is dispensing. right? And athletic trainers are never authorized to dispense medication. So when we look at this, then distribution has to do with how the medications are provided with that. But when we look at dispensing, and by definition, dispensing is taking medication from a larger bottle and putting it into another packaging or giving multiple doses to the patient. And so that's where, despite the relative cost of large bottles, in reality, everything should be individually packaged single doses. That way, all of the necessary information is provided within each dose, right? Because once you give this bottle or give them a few pills of Tylenol, and you put them in another container and they leave, right? They no longer have that information. So even in over-the-counter medications, you should not be dispensing medications, only administering single doses. And so the DEA actually regulates and has very strict policies on packaging and labeling, amongst other things, for prescription drugs. And some of those also come into play in over-the-counter drugs. And so certified athletic trainers should not be assigned duties that should only be performed by physicians and pharmacists. So the physician can have the prescription medication and you can have it in there locked up, but the physician or a pharmacist are the only ones that would be allowed to dispense that medication. Right? You can administer a single dose with that. So like if you have a prescription for, like when we do iontophoresis, we're administering a single dose. That's administration. We would not be able to give that prescription medication to the athlete and then have them administer multiple doses to themselves. With that, these are all of the requirements for documentation of the administration of a medicine. And so when you get into this, obviously, this is where you really have to decide whether or not administering medication is something you want to do, because you're responsible for that medication. And so you can see everything from the basic components with that to the quantity, but then with the lot number and expiration date, in case there is a recall or potential side effect with that from the medication, we would need to report that to the authorities, and they would need to know what manufacturer lot number and the expiration date, so that way they have the information for potential recalls. So all these different things are what should be included on a medication list and should be recorded each time medication is administered. And that leads right into information management and medical records. So when we look at medical records, right, we've talked a little bit about these from risk management and the importance of documentation, but these are everything that should be included. These are everything that should be included within the medical record that you're keeping with them, right? All injuries and illnesses, medications and allergies they're taking, right? Clearances for participations, their immunization records, consent to treat and authorization, all those sorts of forms all need to be in there. And so these consent and authorization forms, right, set the boundaries for proper care and allow the patient to have some say in how their care is done. And so within these consent forms, it often are standardized. They go through legal aspect, and they are legal documents that need to be maintained as such and followed as such. Next is care levels and assigning care. And so this obviously is a very complicated situation. But what I want you to understand here is a couple of different things. The first one being this health care index. And so we've been tracking injuries in sports participation for a number of years. And so what we've done is assign sports in particular for athletes a healthcare index. And this is basically how many or how much time and specific attention does a specific program need. And that's based off of the injury rates, the risk of injury, specifically catastrophic injury, and then the actual exposures, meaning the number of athletes. And so we combine all of this data into an equation that was created by this NATA task force, and it gives the healthcare index for each sport. And then you can multiply that and create the healthcare units, and that will tell you how many athletic trainers you need and how appropriate your level of coverage is. This is something that can be used to try to increase staff at a specific institution, specifically because it mentions everything from the number of athletes to the amount of travel required and taking people away. It's one thing to be able to cover multiple sports if they are both in the same place at the same time, but if you have one sport practicing off campus and another one on campus, it's impossible to be in two places at once, and so you can't really be providing care. There is another document on the secondary school setting. With both of these things, I want you to understand that they are out there, they are resources, and they are things that you need to be aware of as an athletic trainer. If you are grossly understaffed and you cannot provide the standard of care, you are still responsible for providing that standard of care. And the courts have reaffirmed that on a regular basis, that by providing athletics, they are responsible for providing a standard of care to their patients. And these are tools to help demonstrate whether or not that is even possible. And if it's not possible, you need to be using these to have an honest conversation with administration about your ability to provide care. And you want to make sure that that's documented as well. So that way, if there is a problem, it's on the institution, not on yourself. Facility design is one of my least favorite things to talk about, because it just doesn't come up that often, but it is important that you have some basic understanding of this, and that you do, if there is a facility design or redesign, that you are part of that discussion. And so there are some basic questions to answer there, some safety elements that need to be included. We'll go through each of these as well and kind of make a cheat sheet, but there are specific recommendations for non-slip floors and the height of ceilings and ventilation and all these sorts of things that most of the time will be done by the architect and engineers, but you need to know these as well. And there will always be some question on what the height of the GFI should be in the hydro room. Right? I don't even remember that, but we will make sure that you have that. And as you read that, we'll review that for you at the end as well. But the important things to really keep in mind, like in there, is that you do need to have these GFIs for anything, for any electrical modalities, right? And then you need to really pay attention to line of sight, specifically like in hydrotherapy rooms and all that. Half walls, windows are always good so that you can be able to see and monitor in there. The more open feeling the athletic training room is, the better, or especially, some of those large treatment areas where you may be monitoring more than one patient at a time, the better. Now, obviously, you will also need some locations for some private treatments as well. So it's a counterbalance of that. So same sort of thing, some of the general areas, and I mentioned this is because these will be the things that I want you to think about for your semester project when you design your own little workroom for your basketball tournament. And then lastly, physical resource management. Another thing that requires more additional discussion. And so we will discuss this as well a little bit more later, as far as the different funds bidding process and all that. So as always, if you have any questions, please let me know. And for this one, it's important that you do spend additional time reading and asking questions so that way we can get through everything, and we will talk more about some of the specifics later. Thanks.